Right, good evening, everybody. It's 5 o'clock, so I think we'll get started. My name is Shanil Polevich. Before I carry on, can I ask that everybody please mute themselves? There's a bit of background. Thank you so much. Okay, so as I said, my name is Shanil. I'm a member of the Students and Young Professionals in Public Health Committee of the Public Health Association of Australia. I would like to start by acknowledging the traditional owners of the lands on which we live and work. We are joined today by people in all areas of the country, and so we acknowledge the traditional owners of all and pay our respects to their elders past and present. It gives me great pleasure to welcome you all to our Think Tank competition webinar today. Thank you for joining us. Whether you are an entrant, I will introduce the entrants shortly, a judge, I'll introduce them shortly too, or an audience member, it is wonderful to have you with us and supporting the activities of our committee as part of the Public Health Association of Australia. As I've said, please make sure that you are muted if you're not presenting. And I'm going to ask all audience members to please turn off your video sharing as well. I think everybody has, but if you haven't yet, this is just to reduce any kind of distraction while the entrants are presenting. So, as you're all aware, we are here today as part of the National Public Health Student Think Tank competition for 2019. This competition is an initiative of the Students and Young Professionals in Public Health Committee. You'll hear a bit more of the committee, a bit more about the committee a bit later on, but for now I'm going to give you a quick rundown on the competition so far. The competition launched last year in 2018. And the aim was for it to be a way to engage our student audience with the field, giving them a chance for exposure and to capture their energy and innovation. This year, the students entered by providing a written response to the prompt, what do you see as a major challenge facing the public's health in the next 50 years, and how would you recommend it be addressed? We received 32 entries in total. These were reviewed according to a predefined set of criteria, including demonstrated understanding of public health principles, quality of critical thinking, quality of communication, and adherence to referencing style. Our top 4 shortlisted entrants from this written round were then invited to develop their response into a presentation of no more than 7 minutes, which is what we will be hearing today. Our winning entrant this evening will go on to present their response at the national conference as a keynote session. Our winner will receive free registration to the conference and a significant amount towards their flights, accommodation, and conference registration. All 4 of our shortlisted entrants who present today will receive a 1-year student membership to the PHAA. It is with great thanks to the PHAA that we are able to offer this wonderful opportunity, and we thank them not only for their support of the Think Tank competition, but also their dedication to supporting students and young professionals in public health, especially through our committee. I would like to give a special welcome and thanks to our judging panel for today. We're very pleased to have such high-level expertise on the panel. We welcome the PHAA CEO, Terry Slevin. Terry, are you there? Terry was here a minute ago.
I am, so I was just unmuting, Chanel, that's all. Thank you. You're running it beautifully. Thank you for that. And I'm delighted and looking forward to it. This is the second time I've judged this, and it's a very high standard competition. So congratulations to everybody involved.
Fantastic. Thank you, Terry. Our second judge is Paul Gardner, who is a longtime member of the PHAA's Queensland branch and the Equity and Inclusion SIG. Paul, are you there?
I am, Chanel.
Welcome, Paul. Thank you. And then last but not least, Melissa Sweet, who is a journalist from our media partner, Croaky Media.
Hello. Thank you.
Hello, Melissa. Thank you for joining us. Okay, our 4 entrants tonight. First up, we have Hayden Birch from the University of Melbourne. Second will be Kathleen McFadden from the University of New South Wales. Third will be Lucy Corbett from the University of Sydney. And fourth will be Stephen Barrett from the could everybody please mute their microphone if they have not yet done so. Okay, 5:05, we're running perfectly to schedule. Right, with that, we might launch into our entrants. Each entrant has no more than 7 minutes to present their response. So I will be keeping an eye on the time and just I will be giving a sort of wave if you're over time. After that, there'll be an opportunity for the judges to ask 1 or 2 questions at most, and then we'll move straight on to the next entrant. So each person in total has 10 minutes. If there's anyone who's joined us in the last few minutes, please do mute your microphone and turn off your video sharing to help us run things smoothly. All right, our first entrant. I'd like to introduce our first entrant, Hayden Birch. Hayden is an intercalated Master of Public Health / Doctor of Medicine student at the University of Melbourne. So he's basically doing 2 degrees at the same time. He'll be presenting on the topic, Hope for a Meaningful Future, Children and the Rights of the Child as the Public Health Focus for the Urgent Reduction in Greenhouse Gas Emissions. Thank you, Hayden. You can go for it when you're ready.
Okay, the sound's okay?
Perfect.
Okay, so we just review this share screen. Here it is, share desktop. Okay, how does that look?
Perfect.
There we go, okay. I'll fire it away. Actually, I should start with saying good luck to everyone. I think that's really important. So I'm going to talk about climate change and greenhouse gas emissions reduction. And the focus it will be on using children as the avenue for both addressing climate change, but also as unifying the public health field and messaging around all aspects of public health. So advanced slide. So as both a modifier and amplifier, climate change is already exacerbating health inequalities. The World Health Organization has stratified out 5 key consequences, of which the major threats to health will be through rising temperatures, extreme weather patterns, which are then driving patterns of disease change, water and food security issues, vulnerable shelter, population growth, migration, which are impacting on health both directly and indirectly, and especially amongst vulnerable populations, of which children are particularly vulnerable. The key killers of children: undernutrition, acute respiratory infections, diarrhea, malaria, other vector-borne diseases are all highly sensitive to changes in the climate. So as the slide diagram by the Lancet Commission shows, climate change has been determined as the greatest health threat of the 21st century. So the key public health principle would be that this issue is the top tier issue for certainly the next 50 years, but ongoing the next century. And my second point would be that it is today's problem. So aligning our public health efforts, and whether that's in gender equality or in obesity and chronic disease prevention, health policy and promotion. My contention is that we have both a global imperative and there's a huge win-win opportunity for the betterment of public health to unify behind young people as a solution to all of these issues. So 1989, the world united around, or most of the world united around the Convention on the Rights of the Child. And we agreed that in a world in which children have the right to survive and grow in a healthy physical environment, it was a key principle for the world that we want to see. A deeper component of the convention is also participation, and despite changes to our world, we know that children themselves are rarely included in discussions on climate change and certainly on how to respond to it. And in addition to that, the right to health is also recognised as a key component of the Convention on the Rights of the Child. So a focus here on children and on child rights in adaptation and mitigation of climate change is what I see as a real window of opportunity. We have an issue that's not going anywhere and that we need to address. You know, we have a framework or an approach through child health and child rights, and applying that to our public health frameworks is the opportunity. And so I want to give a couple of examples to put it in practice. And my first one is the obesity epidemic, of which my term here is an intuitive justice. But I think what we see is that communities really have an increased willingness to provide, to accept, you know, what public health call, you know, proportionate increased public health regulation in order to protect our child's health. You know, and you know, for example, that can be you know, around you know, our willingness for increased you know, packaging regulation, for changing you know, transport methods around schools. You know, for example, the bicycle network has been able to introduce a national strategy for active transport for children to school. So we're looking at a co-benefit there towards children's physical health, their mental health, their likelihood of disease into adulthood, and there are also a key reduction in greenhouse gas emissions through active transport over use of vehicles. My second example is around refugee and asylum seeker health, and this is more a proof of concept where I think certainly the last decade, this has been a really challenging policy environment, but we've seen some really significant headway made in advocating for refugee and asylum seeker health through children's health being the key argument. Whether that's been through, you know, Kids Off Nauru or the Royal Children's Hospital being quite vocal, and of course with the recent Medivac bill as well. Finally, and with my limited time, there are global precedents, and I think a key message which you know, unites all sides of politics is that, you know, Australia is being left behind by the world on this climate issue. And there are examples worldwide where other countries are combining a child-centred approach to mitigating climate emissions and having great outcomes, with the diagram on the right here from the United States, where you can see a real focus on premature deaths, asthma and respiratory diseases in children as a focus for the Obama administration's Clean Power Plan. So to finish, ultimately, children do deserve a hope for a meaningful future. And I really contend that taking a child-focused approach to all of our public health areas is an important step, and also poses the greatest health opportunity for this century.
Fantastic. Thank you so much, Hayden. I'll turn to our judges. Do you have any questions for Hayden?
Hi, Hayden, it's Terry. Can you hear me?
Yeah, hi, Terry.
Hayden, thank you for that. That was an excellent exploration of some of the biggest challenges that we face. And your broad response relates to a child-focused approach. Can you articulate, and I appreciate it's a big challenge, as to how you might actually translate that into a specific advancement when it comes to public policy or practice in Australia?
Yeah, okay. Which I think is the challenge to do in 7 minutes to give us some more specifics. I mean, I'm based in Victoria, so I'll give you a Victorian example, and that would be that our Victorian Health Minister, Jenny Mikakos, you know, it has been quite clear that her agenda as health minister is around child and familyhood or family obesity. So a real practical you know, co-climate, co-childhood obesity strategy would be to be promoting active transport and increasing plant-based diets as the key focus for dealing with both issues. In some ways that can mean that the approach would move away from, say, like a star rating on food packaging, and more towards active transport and plant-based diet, as an example. But the benefit there would be that you're unifying or combining the two silos of public health, coming towards the political sphere with the one message, and then dealing with the politics, the economics, the community, all with one united voice.
Thank you.
Okay, thank you so much, Hayden. I think we're going to move on to our second entrant now. Our second entrant is Kathleen McFadden. Kathleen joins us from the University of New South Wales, where she is a Masters of Public Health student. Kathleen will be discussing the topic of subsidised assistive technology recycling scheme and care network system to aid ageing in place. Thank you, Kathleen. Over to you.
Great. Thanks, Chanel. Can everyone hear me? Sound
Yes.
okay?
Yes.
Right. No worries.
Kathleen's video is not working, by the way, but she will be able to share her screen.
Yeah, sorry about my camera, everyone. So thanks, Chanel, and thank you, Hayden. That was fantastic. So hi, everyone. Thanks for having me. My name's Katie from UNSW, and I will be speaking about ageing in place today, how it presents future challenges for Australian public health, and a few ideas on how to address these challenges moving forward. So what's the context? In Australia, we know that the 65 plus age cohort has been steadily becoming a larger proportion of the population over the last century. And this is credited to factors like increased life expectancy and improvements in healthcare. So over the next 40 years, the Australian population aged 65 plus is actually projected to double to almost 9 million people, as you can see on the screen. So the most obvious problem associated with this shift in demographics is the sheer number of people who are going to be requiring care over the next 50 years. And so naturally, questions about providing future aged care for Australia, questions about workforce or infrastructure or quality of care, they all usually revolve around this theme of quantity. And quantity of people is certainly a problem, but a secondary issue which really needs to be considered in conjunction with the quantity of people is the actual model of care delivery. And I guess what I mean by that is that older people prefer to age in place, which is to remain for as long as possible in the home of their choice. So the core issue is not just 9 million ageing Australians all receiving care, it's actually 9 million Australians all receiving care in their individual homes, each with unique circumstances. And ageing in place is not simple policy-wise. There is a suite of challenges which stem from this choice. So firstly and most functionally, declining abilities and capabilities go hand in hand with ageing. So this means that as people age, homes are becoming less suitable and less safe. Almost 40% of people who are ageing in home or in accommodation require assistance with their daily living activities. So this means that at best, under-equipped houses present some logistical issues for older people, like difficulty negotiating stairs. But at worst, houses which are not age-friendly can present some serious health risks, like slipping and falling, for example. A second key issue is loneliness and social isolation. Loneliness has been shown to have correlations to depression, dementia onset, and risk-related behaviours. So while growing old in a familiar environment in their own home may be comfortable, the risk of loneliness for those who are choosing to age alone in their own home rather than in an aged care community is much higher. And finally, a third problem is the reliance and pressure on informal carers. So almost 3/4 of older people receiving care at home depend on an informal care provider. And then if informal care requirements double, which the age 65 plus cohort is expected to, this means that Australia will be relying on almost 500,000 informal primary carers by 2057. So how can we address the issues which arise from ageing in place? And I'm going to present two ideas today. Both are preventative policy measures which embrace and reimagine the use of technology. So firstly, implementing a national assistive technology recycling program. So assistive technologies, or ATs, covers a broad range of devices. It goes from mobility aids like wheelchairs to walk-in baths to vision or hearing aids. And a cost-benefit analysis conducted in 2018 estimated that using ATs could actually save up to $300,000 per person over 5 years. And the way we see those savings is because the use of ATs can improve health, safety, and happiness. And then these outcomes manifest as things like fewer GP visits and fewer hospital admissions. But despite these predicted savings, a basic issue is that AT are not cheap. There's some examples on screen of some pretty expensive assistive technologies. So the bottom line is that basically a single use of an AT device by only 1 or 2 people is just not cost effective or sustainable. So an alternative proposal, therefore, is to consider an assistive technology recycling scheme. And in my head, this policy would involve the reuse of assistive technologies for multiple consumers over many years. To make the program more economically viable for the government, I would recommend the government subsidise the CapEx costs for each individual. So each individual that takes an assistive technology gets their costs subsidised, but then the operational costs are uncharged to the users. And so, of course, when secondhand technologies are considered, a core problem is the product quality, the lifespan, and this idea of planned obsolescence. So technologies only lasting 10 years or less. So if the government were to introduce a funded AT recycling scheme, I believe that it would incentivise AT designers to start designing for sustainability and for longevity, because their product's reusability factor might actually win them the large government contracts when they're looking for these long-lasting ATs. So with technology waste being such a topical problem, an aged care scheme which has a secondary benefit of sponsoring sustainability would be well received, I think. So would this actually work? Can a reuse policy incentivise more sustainable design procedures in the market? And yes, it can. Regulatory changes constantly change markets, and a specific example is on screen. It's the Clean Air Act in America in 1970, and this policy instigated some radical changes, both in car technology and power plant technology and more, to design more for sustainability based on that regulation. So that brings me to my second suggestion, which is that there needs to be an integrated social and care network for the elderly, their friends, families, and carers. So in my head, this is basically a combination of My Health Record and Facebook. And we are seeing technologies like this emerge privately, but there's nothing that's on a wide government scale, which is what I think we really need. So excuse my pretty bad diagram, but here's an example of what I believe the network could look like. So on the left, you've got your social aspects. So if I'm a friend or a family member, I can engage socially with my loved one remotely, similar to Facebook. If I'm a carer or a health professional, in the middle section, I can both engage socially and access and add to my patient's medical records. On the right in blue, if I'm a home care provider, I have a detailed understanding of my care recipient's health record and their history. And then if a care recipient changes providers, all of their details, all of their preferences, their notes are kept and they're easily transferable. So on an individual level, a well-designed network will help to increase the independence of those who are aging in place while simultaneously decreasing their loneliness and isolation. System-wide, I think this idea would improve the transparency between all levels of the health system, similar to My Health Record. So it would provide a one-stop shop for medical and care information, but I see it as also having the capabilities for care recipients to record their own symptoms and preferences and notes. And consequently, that would improve the efficiency and quality of care given to individuals in their own homes. So yeah, that's it. Thank you for having me and appreciate your time.
Fantastic. Thank you so much, Kathleen. Judges, we have time for one question.
I'll go if nobody else does. Melissa, Paul? No, I'm hearing silence, so I'll press ahead. Thank you, Kathleen. That was helpful and very, very informative. Some interesting ideas. How do you predict the capacity of the aged care target of your proposals in terms of their capacity to engage in the digital world, the use of Facebook, My Health Records, the digital platforms, and their capacity to adapt to its best use? Do you think that there's sufficient capacity to do that, or do you think there would be a component of the program which requires some upskilling?
Yeah, that's a great question. So you mean the consumers of the age of the network?
Yes.
So that the aged people, yeah. I think that an upskilling would be required, but I think we'd actually be surprised by how many of the older generation are actually online and using technology in ways that we didn't think they would. So I don't think actually upskilling would be too much of an issue. The way I see it is there would be age-friendly components of the network. So like things like big buttons, bigger writing. So it would be age-friendly, but I think the technology transfer to the elderly population is not actually that much of an issue. Of course, there'd be training required, I guess, as with any new program, but no, I don't see that as too much of an issue.
Thank you.
Thanks.
Great. Thank you so much, Kathleen. All right, I think we're ready to move on to our third entrant, who is Lucy Corbett. Lucy is a PhD candidate at the University of Sydney. She'll be presenting her response titled, Burnt Out, an Organisational Approach is Necessary. All right, Lucy, over to you.
Can you hear me?
Yes, but not super well. If you just speak up, I'm sure it'll be fine.
Okay, is that better?
Yes, that's good.
Okay, so thank you for having me. Recently, there has been a proliferation of articles in the media calling millennials the burnout generation, sparking a debate on the burnout phenomenon and how it should be addressed. Whilst not currently classified as a medical condition, the World Health Organization defines burnout as a psychological syndrome resulting from chronic workplace stress that has not been managed. Burnout is characterized by 3 dimensions: exhaustion, depersonalization or feelings of negativity related to one's job, and reduced professional efficacy. In a society that experiences many socioeconomic challenges, workplaces often place pressure on their employees to perform, resulting in workers experiencing work-related stress and exhaustion, the most prominent signs of burnout. From teachers and medical staff to tech gurus and those in the financial sector, every worker is at risk of developing burnout. The prevalence of this phenomenon has increased in recent decades to alarming rates and will continue to rise in the future unless an organisational approach is taken. As you can see here, burnout is an enormous problem because of its impact on an individual's physical and mental well-being. Exhaustion from work is correlated with stress outcomes and hence can lead to similar physical symptoms, including headaches, hypertension, among others. Additionally, burnout can also contribute to the development of mental disorders, substance abuse, and suicidal intention. Since burnout can occur in any workplace, these health impacts are extensive. An abundance of organisational risk factors have been identified across various professions. Here, you can see the 6 main organisational factors associated with the development of burnout, including workload, autonomy, relationships, and recognition. Despite the numerous organisational risk factors that contribute to burnout, most interventions have focused on individual health-based strategies, such as mindfulness, resilience training, or time management strategies. However, Public health leaders need to explain that these individual level interventions alone are not enough and will not prevent the increasing rate of burnout, as they fail to address risk factors in the workplace that contribute to the burnout problem. Instead, a proactive organisational approach is needed to prevent the occurrence of burnout by reducing factors that increase the risk of stress. A supportive workplace culture that values employees can increase work engagement. Thus, organisations should give employees input into decisions that affect their work, have a consistent reward system, resolve conflicts quickly, and act fairly towards all staff. These primary prevention strategies are most effective and far-reaching for reducing the incidence of burnout. With protective factors embedded in the workplace culture, the prevalence of burnout will continue to be problematic. Currently, some companies pride themselves on the 9-to-9 work culture, believing a commitment to long hours demonstrates a good work ethic and productivity. However, in a study of physicians, for every 5 hours of work over 40 hours, the odds of developing burnout increased by 12 to 15%. Organisational leaders need to recognise the detrimental impact of a high workload and long working hours has on employee engagement. As people in public health, we need to advocate for evidence-based workload management strategies so that CEOs and managers can incorporate them into company culture. This is of particular importance in the technology age, where the proliferation of smartphones has increased the connectivity between employees and employers, blurring the boundaries between work and private time. How often do you respond to an email or take a phone call outside of office hours, on a weekend, or during leave? You're not alone. However, research shows checking emails less frequently reduces psychological stress. Therefore, a company-wide policy to limit the internal communications during personal time should be established to create boundaries. Instead of relying on employees after hours, leaders need to embed strategies in the workplace to manage workload. One strategy involves frequent self-evaluation, allowing employees to rate their perceived workload. Managers can then see where tasks should be delegated or shared among others. A collaborative project between Deakin University and Victoria Police took a similar approach, utilising an online workload management system which was successfully implemented into 2 police stations, with junior officers feeling more supported. Public health leaders should look for opportunities such as this to partner with organisations to implement and evaluate organisational intervention strategies to encourage companies to take accountability for the management of workload to promote work engagement. Burnout can be contagious. People who are experiencing burnout have a negative impact on their colleagues, as their cynicism towards work may disrupt tasks and cause more personal conflict. Conflict among team members and a breakdown in the community at work has been shown to increase burnout, so burnout can be spread throughout the workplace. Therefore, organisations need to create a supportive environment. To create a sense of community, companies should develop support networks within the organisation. This should include peer support groups, formal support via performance evaluation and regular feedback, or the use of a community-based approach. It is an organisation's responsibility to nurture a supportive, community-focused environment which will reduce depressive feelings associated with burnout. Action needs to be taken now to prevent further increases in burnout globally. The gravity of the issue is indicated by the indiscriminate nature of burnout in conjunction with its associated health impacts. To reduce the effects of burnout, organisations need to be aware of their vital role in reducing burnout by developing a protective culture. Unless an organisational approach is taken to prevent burnout, this phenomenon will become a major public health issue in the future. So, thank you.
That was excellent. Thank you so much, Lucy. All right, now our judges to ask a question. I'm going to give Paul and Melissa the first opportunity to ask a question.
I've got a question. I might be wrong, but I thought in some countries there was actually legislation about hours worked in Denmark. So I wondered if there was any examples of legislative approaches around burnout.
So in Australia, there is a policy that's conjoined with work health and safety as to how workplaces should be protecting the psychological health of workers through the management of workload and work hours. But from experience, it doesn't seem to be as discussed as much in the workplace over here. As for Denmark and other European countries and their legislation, I'm not entirely sure.
Okay, great. Perfectly on time. Thank you very much, Lucy. Okay, it's time to move on to our fourth and final shortlisted entrant, Stephen Barrett. Stephen is a PhD candidate at La Trobe University in Bendigo. He will be presenting his response titled, Our Children's Future, Addressing the Childhood Obesity Crisis. Thank you, Stephen.
All right. Have I shared my screen?
Not yet.
Not yet. Here we go.
There we go, we've got it. Yes,
right.
Thank you.
You can hear me?
Yes.
All right, very good. Thanks for having me. Well done to everyone who's presented so far. So when I sat down to think about this, what's going to be the biggest problem for the next 50 years, I think I couldn't look past what's a serious problem now, and that if left to run unabated, it will become a catastrophe in the next 50 years, which I think is childhood obesity. There we go. So they're my children, 1, 3, and 5. And I know as you move from, say, 1 to 5, you get more choices in life, but ultimately their care falls down to me and my partner. And the care of the children in the community falls down to us. We owe it to the children now and in the future to look after them. And the sad thing is that despite advances in technology, in health and medicine, because of obesity, our current generation are actually more likely to die at a younger age than their parents, which is quite sad and doesn't even account for morbidity and mortality. So at present, roughly 1 in 4 Australian children is overweight or obese. The proportions rise higher in socially disadvantaged groups, and 1 in 3 Indigenous Australian children is overweight or obese. If you're living in an area of social disadvantage, it's highly likely you'll have access to fast food, and it's quite unlikely you'll have access to recreational parks, maybe even footpaths. Children living in remote communities, well, often it's cheaper to buy junk food than it is to buy fresh fruit and vegetables. So it goes far beyond individual choice what's driving this problem. And the main concern that I see is that this problem hasn't necessarily crept up on us. It's been growing for 20, 30 years, is that despite this, we don't have a clear strategy here in Australia for how to address it. And that's where we want to talk about today. So globally, there's about 45 million children who are obese. And the WHO thinks that maybe by 2025, that will rise to 75 million. Now, the only tiny fragment of positivity out of that is maybe we can learn from other countries, because we're all facing this together. But even that's probably a stretch. So in the UK, they've banned junk food advertisement on public transport. In Chile, they've enforced food formulation changes, and that has decreased consumption habits amongst parents and adolescents. And in Mexico, they've had the sugar tax for over 2 years, and they've seen a decreased consumption in sugar-sweetened beverages year after year. So the evidence is there. We know what's working. In Australia, well, we've gone for the voluntary labelling system. So, and you know what happens when you let industry self-regulate, we'll call it. There's also issues about how it's rated and how, I suppose, two things. One is how Greek yogurt has a lower health rating than Baby Shark Fruit Loops. The other question would be why anybody would want to eat Baby Shark Fruit Loops in the first place, I think. So what are we doing? At the moment, in Australia, we're working at the tip of the iceberg. So government policy is based around individual behaviour change, education campaigns to talk about what to eat and where to exercise. And that's fine. But education campaigns are undermined when you're living in an obesogenic environment. All of that work is undermined by what's happening below. So the real problem, the proliferation of fast food, the advertisement to children, the decrease in physical activity, these are the real undercurrents that impact individual behavior change. So if all our policies are based above the waterline, then we're not really going to get anywhere. So what do we need to do? We need to take from the evidence and find a way to move it into Australian context. So we need policies to reduce consumption of sugar-sweetened beverages, the #1 cause of added calories, the #1 cause of dental caries, the #1 cause of childhood obesity. Worked in other countries, we need to take what's worked and move forward. The regulation of unhealthy marketing to children, we know they're susceptible to marketing, especially as they move into adolescence when they get their own purchasing power. We know the pester power, how it can have an influence. And finally, we need to develop public transport policies and urban planning policies to encourage more active transport, be able to walk to school, to have active play, to be able to have walkable neighborhoods. So these are major things that all need to be done. They're all working in different countries in bits and bobs. We've got a chance here in Australia to pull it all together for a comprehensive plan. But of course, there's a gap. So in my work and our research, we work on individual behavior change with patients, a lot of whom are overweight and obese. Now, overweight and obese patients, by and large, know what they want to do, and they know what they need to do to get there. But there's usually a gap as well. So we don't tell them what to do. What we try and do is we look for the answers within them, and usually within their social network. Friends, family, sometimes we bring in healthcare workers to scaffold around them. We want the right people at the table who can make a meaningful impact for those. And generally, we're finding we're getting good results. I thought this parallels to the gap in the Australian context, because we need the right people around the table. I think if you want to have a meaningful impact on childhood obesity, we need to have a national Australian task force for childhood obesity. There's no other way. It's too political, it's too emotional. We need to have the right people around the table. So that includes academics, clinicians, policymakers. We need consumers who have issues, who suffer from obesity, parents and children. But we also need the food industry there. We need marketing agencies. We need physical activity groups. They may not all sit at the same table at the same time, and we know there's going to be disparate points, but we need to find some sort of level of convergence. We can't fight them individually. We can't sit there while they dole out the nanny state rhetoric. We really need to push on and formulate an almost bipartisan or apolitical platform to do this. I think it's probably the only way our children's future is at stake. Thank you.
Thank you so much, Stephen. That was wonderful. All right, judges, any questions for our final entrant?
I'll start off. Really interesting presentations from all four speakers. Stephen, I just wanted you to touch a little bit further on, you talked about equity issues and how obesity is strongly related to socioeconomic status and various other things. How do you see we could address that to act on childhood obesity?
Sorry, could you ask that once more, please?
So you were talking about how around equity issues, so socioeconomic status, you know, Aboriginal and Torres Strait Islanders, remote communities. How could you tackle obesity from an equity angle?
That is a good question. We know there are major issues in especially rural and remote communities around how they access food. I suppose at an individual level, it's important around what we eat and how much exercise we take, but we know that nutrition is probably the primary driver of obesity. In these especially rural or remote areas where you have logistics around transportation, storage of food, it's often easier for shop owners to hold non-perishable items that can last a long time and have a high markup rather than fresh fruit and vegetables. So I think along those lines, we would probably need a degree of government assistance. That might mean broader context for the government to work with growers, probably doling into what Hayden was saying, working with transport companies, because there's a lot of haulage involved. So there needs to be a roundtable agreement. But I think government have a strong role to play in perhaps, if possible, subsidising the price of fresh food. Perhaps if maybe they have the real ambition for it, if you do elicit a tax, whether it's a sugar tax or an unhealthy food tax, can you directly proportion from that tax to subsidise some of the fresh food and vegetables?
Thank you so much for your answer, Stephen. Okay, a huge thank you again to all of our shortlisted entrants for taking the time to enter our competition and present this evening. And a big thank you also to our students and Young Professionals Committee and the Public Health Association. It's been fantastic to hear all of your ideas, and we hope it's been a valuable opportunity for everybody. The judges are now going to be deliberating on the presentations we heard today. They have a few minutes scheduled to do so. So in the meantime, one of our committee members, Ian, has prepared a short presentation about our committee, just to fill the time while the judges are deliberating. And hopefully, upon hearing more about our committee, you'll be really keen to join us and join up in some of the exciting activities that we're part of. Okay, Ian, are you there?
Yes, I'm here.
Fantastic.
So basically, the Students and Young Professionals in Public Health Group is a PHA of the PHA, is a portal for students and young professionals interested in public health to maintain and expand their professional circles, peer networks, and improve their career prospects in public health. And so the group is led by a dedicated committee of young professionals who act as an advisory for and oversee the activities of students and young professionals at a national level, with close links to state branch students and young professional representatives. And so currently there are a number of activities led by the SYPBH committee other than the National Public Health Student Think Tank competition, which is happening right now. And so one of the programs is the National Mentoring Program, where 25 mentees have been paired up with mentors with the primary function to provide a way to initiate a mentee-mentor relationship over the course of 6 months. And so the program is purposely flexible and designed to allow mentees and mentors to work together in identifying the mentoring needs of the mentee, and also to develop corresponding objectives for the mentee-mentor relationship over the duration of the program. I guess secondly, we're also currently putting together the background document for the PHAA on health policies, such as public interest journalism and why it is important for public health. And we have a number of experts from the field involved that we're liaising with as well. And I guess we have representation on the PHA conference events, organising committees, such as the upcoming Australian Public Health Conference later in September this year in Adelaide. And for those of you who will be attending, SYPBH, in collaboration with the PHA South Australian branch and the Australian Health Promotion Association South Australian branch, will host the Students and Young Professionals in Public Health Networking Night. And that'll be prior to the start of the conference. And so that'll be on Monday, the 16th of September, from 6 to 9 p.m. at the iconic South Australian Health and Medical Research Institute, or the SAMRI building. And that's South Australia's independent flagship health and medical research institute. And it's also known as the Cheese Grater. So a light supper will also be provided. And I guess it's an opportunity for students to meet other students and young professionals to meet other young professionals. And it'll involve a World Cafe style session to network and gain some handy career insights from some of the attendees, especially first timers, to meet. And so there'll be some familiar faces for you to approach during the morning and afternoon tea breaks. And so local students and young professionals, especially based in Adelaide, who are unable to attend the Australian Public Health Conference are also encouraged to attend. So the advertisements and the registrations are now up on the PHAA and the conference website. So there's more information and more details there. And I guess finally, the SYPPH committee continues to develop some exciting new opportunities for students and young professionals. And there are many ways that you can be involved with the PHA and the SYPPH activities. And if you haven't already followed us on Twitter, that's at PHAA_SYPPH, all in capitals, or you can email us your thoughts at sypph@phaa.net.au. Great, back to you, Chanel.
Great, thank you so much, Ian. That was very comprehensive. So we still our judges still need another minute or two. So I don't know if anybody has any questions for us about how the committee runs or on any of our activities that are going on. Okay, I think that's a no. All right, our judges do still need a few more minutes. Okay, Ian, you were really, really speedy with that. Ian, would you be able to give a little bit more information on the mentoring scheme and roughly when you might launch?
From my understanding with the mentoring program, the mentees have already been paired up with some mentors, and over the next course of 6 months, there'll be some processes to basically have some mentorship between the mentee and the mentor. And hopefully it might be an opportunity for the mentees to gain some knowledge in public health and also to further progress in their careers, as well as the mentors to give them an opportunity for them to mentor some of the mentees and gain some experience from that as well.
Fantastic. It's such an exciting program, and I know it's something that we've been wanting to launch for a number of years, so it's really, really good that it is happening. I think that our judges are all done. Terry, are you ready to present your results?
I am. Thank you, Chanel.
Excellent.
I would be wrong of me not to start by thanking and congratulating all of the folks on the SIF committee who've put this together. This is the second time that we've done this. The process from my end, at least, has been extraordinarily smooth and efficient. But probably far more important than that, it's created a fantastic opportunity for the next generation of leaders in public health to take on a challenge and demonstrate their capacity and their passion. And so it's worth firstly recognising the large number of entries this year. Am I right in recalling it was 35 written entries in the first round?
32, yes.
32. So 32 entries in the first round, and the tough challenge of bringing it down to the 4 wonderful finalists. So thank you to the group who's initiated this and then who's administered it to this point. It's been an extraordinarily effective and efficient way of creating opportunities for our next generation of public health leaders. The second thing I should say is to congratulate all 4 of the finalists. When you make it to the top 4 out of 32, you should be very proud of your efforts. And so congratulations are deserved just to get to this stage of what is clearly a tough competition. I can tell you from last year that there was a number of people who are at graduate level or master's level who were in the finals, and there were clearly a difference in terms of the duration of people's academic career, and I think that showed in the final round. The judging for this round is more difficult because I think the finalists are at much more similar levels in terms of the development of their academic career. And that made it that much more of a challenge, I think, to judge. And making it a tough competition is a good thing, and you should all be congratulated for that. If I can quickly offer some commentary to all 4 of the candidates, firstly, kicking off with Hayden and really laying out the most extraordinary public collection of the public health challenges we face into the next 50 years or more. Hayden, you've captured those very efficiently, and with that Lancet Commission report that was published in the Lancet in April, you've, I think, captured really the big picture when it comes to public health and the challenges that exist in front of us. And putting forward that child-focused approach, I think, is a very important way forward to influence all of our thinking. The second one for Kathleen, and very clearly articulating the other end of these ages, the stages of ageing, and talking about the challenges when it comes to aged care and the future for our older population. I thank you for paying attention to that. I'm approaching that myself, so it's very personally appreciated. And of course, we all have people in our family who are wrestling with those issues today. And so you've articulated the challenge that lies before us. And also you've put forward some very clear and tangible solutions that might be constructive and productive when it comes to taking on those challenges. Lucy, with regard to your work on burnout, I think it is a very important issue. I'm a bit worried about the number of emails I'll be doing tonight and on the weekend. I thank you for reminding me of that. We all wrestle with that, and the availability of our work device that we carry around with us pretty much every waking moment is an important issue to raise, and highlights a question that I suspect not enough of us have given sufficient thought to. So highlighting that and some of the solutions towards it, and going beyond a simple aphorism of a work-life balance, I think was a very valuable part of your contribution. And Stephen, bringing up the final presentation and putting forward that very major public health challenge on on childhood obesity and the various solutions that we have seen implemented around the world, but bring it together in a governance model that tries to find practical solutions to a very substantial and internationally established and enormously difficult challenge. You've captured the evidence as I understand it, and so congratulations to you. So on the front of all 4 candidates, you all deserve your place in the final, and that was clear by your presentation. But I've been following the scoring of the judges through the Google document structure that's been available to us. And we do have a unanimous outcome, and I thank Melissa and Paul for their contributions and their wise input to the judging process. But I'm delighted to announce that the winner for the award for 2019 is Kathleen. So Kathleen, congratulations for your efforts. And on a personal note, I'll be talking to my mum in the car on the way home.
Oh, that's fantastic. Thanks so much.
A very deserved winner. Well done, Kathleen.
Thank you. Thank you so much for the opportunity, and to the other contestants and to the judges. Thanks for everyone's time. Really appreciate it.
I was really, really overwhelmed by how high the quality of all 4 of your presentations were. I'm so glad that I wasn't a judge, because I honestly would not have been able to pick just such high quality presentation skills, critical thinking. I've way above some of the qualities that I've seen at some of the top conferences. So really congratulations. Kathleen's going to be presenting her presentation as a keynote at the Australian Public Health Conference in Adelaide in September. And she'll be getting significant support towards her registration, flights and accommodation. And all 4 of our wonderful entrants will be receiving a 1-year student membership to the PHAA. Congratulations to all 4 of you. Judging the written entries was such a tough process, but the 4 of you definitely stood out as the highest quality, and you should be congratulated for that. Thank you especially to our judges for your time, Terry, Melissa and Paul. We really appreciate your time and your wisdom. And a huge thank you to Croaky, our media partner, who will be working with some of the entrants to publish their topics. And of course, Melissa from Croaky, who's given up her evening to help judge our webinar. Thank you very much to our audience members for joining in. We appreciate your participation, and without you, we wouldn't even have a webinar. Thank you for your time. And of course, we encourage everybody to participate next year, and hopefully we'll have even more entrants next year, and the judging will be even harder. But yes, thank you all very much. And at 6 o'clock on the dot, we'll draw to a close. This has been recorded and will go up on our website as well. So if you want to share the clip with any of your friends, you can. But yeah, thank you all very much. And I hope you have a wonderful evening.
Well done. Thanks, folks.
Thank you.
Thank you. Good night. Bye-bye.
Good night. Thank you.